Hi, my name is Joe Bellick, and I'm the founder of Bellick Law, LLP. We are proud sponsors of the Mesothelioma Research Foundation. We have been honored to do this work for 25 years, representing people with mesothelioma and their families. And part of our commitment to our clients is to give back and sponsor research and advocacy efforts and engagement across the mesothelioma community.
Hi, I'm Trey Branham. Dean Omar Branham and Shirley is proud to sponsor this year's Mesothelioma Applied Research Foundation Conference. The 34 lawyers at Dobbs have more than 400 collective years providing legal representation to victims of this insidious cancer. We applaud the leadership of MARF and this community for its tireless dedication to finding a cure for this totally preventable disease.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
Welcome to this episode of MesoTV. Today we're going to talk about what to expect surgery. We have with us today Dr. Melissa Culligan from Temple University Hospital, where she is the Director of Thoracic Surgery Research and Co-Director of the Temple Health Mesothelioma and Pleural Disease Program. Hi, Dr. Culligan. How are you? And could you tell us a little bit about you and your program?
Sure. Hi. Thank you so much for having me, Julie. It's an honor to be a part of this and help educate the mesothelioma community. So it's a great honor for me to be here. Thank you. So yes, Melissa Culligan. I'm a thoracic surgery nurse. I've been taking care of patients diagnosed with mesothelioma since 1987, and I have watched the field grow, where there's more innovative surgical techniques, combination treatments for mesothelioma, including immunotherapy, chemotherapy. And when I started, there was nothing. So this is a very exciting time to care for people with mesothelioma because we have a lot to offer them. I recently finished my PhD at the University of Maryland School of Nursing, and the focus of my doctoral research was the experience of patients treated with lung-sparing surgery, looking at both their quality of life and their dyspnea experience before and after surgery. So I'm happy to answer any questions and share my knowledge and experience with you today and the mesothelioma community. So thank you.
Awesome. And you work now at Temple with Dr. Friedberg, correct?
Right. Yep. I'm at Temple University Hospital in Philadelphia, Pennsylvania. I work with Dr. Joseph Friedberg, who is a pioneer in lung-sparing surgery for mesothelioma. I work as part of the Temple Health System mesothelioma program, where we care for patients at both Fox Chase Cancer Center and Temple University Hospital. So we have a team of medical oncologists, radiation oncologists, thoracic surgeons, thoracic oncology nurses, expert pathologists, and chest radiologists. It's sort of as a team take care of these patients.
That brings me to what we're talking about today. We're going to talk about a surgical procedure performed for pleural mesothelioma, which is the pleurectomy and decortication, which is a procedure performed where you work. Could you briefly explain the procedure and how it helps to treat mesothelioma?
Sure. So historically, mesothelioma was originally treated surgically with what's called an extrapleural pneumonectomy, and that is removal of the entire lung and involves structures including the pericardium, which is the lining of the heart, the diaphragm, which is the muscle barrier between the chest cavity and the abdominal cavity, and then any other structures that were, involved or invaded by mesothelioma. So that left patients with one lung, obviously, because we took the other one out, and it was a very effective, treatment for mesothelioma with respect to surgery. But again, as treatments evolved outside of surgery, it was, we weren't able to offer some patients certain treatments because they didn't have both lungs. So I'm not gonna be able to tell you how many years ago, but years ago, the field has kind of shifted towards lung-sparing surgery. So lung-sparing surgery, obviously, we spare the lung, and we call it extended pleurectomy decortication. There's actually a lot of different terms used in a lot of different centers. So there's not a beautiful consensus on terminology, but essentially what lung sparing surgery is removal of the pleural space, the pleural lining. So the pleura has two sections. It has what's called the visceral pleura, which is up against the lung, and it has the parietal pleura, which is up against the chest wall. And the pleura kind of coats or touches every surface of the chest cavity, up against the esophagus, the chest wall, up against the pericardium, along the diaphragm, and the lung. So when we say extended pleurectomy, what that means is the surgeons remove the entire pleura, both the lining of the lung, so the pleura that's up against the lung, and the pleura that's up against the chest wall. And also, when we call it extended, sometimes if the diaphragm is involved, the diaphragm will be resected and replaced, or it will be, maybe a small amount of it will be resected and repaired, or sometimes it's just cauterized, or if it doesn't appear to be involved, it's left alone. So the extent of that surgery, in many respects, will depend on what we say the intraoperative findings, or once the surgeon gets into the chest cavity, what exactly do I need to do to render this patient without any evidence of disease. And what that means is the surgeon will remove everything that he or she can feel or see. And to what extent that has to happen is really what we call a game day decision. So you go in with the intention of removing all visible or palpable disease. And that's what's called a macroscopic complete resection. So everything you can see and feel. With mesothelioma surgery, unlike other surgeries, we can't say we got all the disease. And the reason why is we are 100% leaving behind what's called microscopic disease. Because of the way mesothelioma grows within the chest cavity, we can remove everything we can see or feel, but we know we're leaving tiny cells left in the chest cavity. And we can talk a little bit more about what we do about that microscopic disease. But what we can kind of explain is if you went in a room and removed all the paint from a wall, you scraped it and it looked perfect, looked like it was paints all off the wall. But if you had a microscope and you looked at that wall, you're 100% going to see little micro paint chips still on that wall. And essentially that's what mesothelioma, that's the mesothelioma issue.
Makes sense, yes. Looking at this procedure, what types of patients would typically be considered as a candidate for the surgery? Sure. There's a lot of questions, yeah.
So surgery for mesothelioma is two things. It's considered investigational, and it's something that we do in combination with other treatments. So a person diagnosed with pleural mesothelioma needs to make sense from a cancer standpoint, and from a safety standpoint. So we can talk about the safety standpoint first, because if it's not safe, then it doesn't matter if it makes sense from a cancer standpoint. You're not going to take a patient to the operating room. So from a safety standpoint, anyone that we're considering taken to the operating room for, I'm going to call it lung sparing surgery, because I think that encompasses everything. It just makes more sense.
Yes.
For people to wrap their heads around. So
Yes.
how to make sense from a safety standpoint. Patients have to have good performance status. What does that mean? They've got to be able to go up and down stairs and kind of engage in their normal life, their normal activities of daily living. They've got to have adequate pulmonary function, and we measure that by putting patients through what we call PFTs, or pulmonary function tests. And those are tests that, very common tests, but it measures not only the patient's lung volume, but how well their lung functions in taking up oxygen. So do they have adequate lung function? From a heart standpoint, is their heart fit for a general anesthesia and a prolonged surgery? So all of our patients see a cardiologist, and depending on what the cardiologist says, do they need an echocardiogram, so a stress test, or nothing at all. So they've got to have good pulmonary function, good cardiac function, and good physical function. The other important thing is that they've got good nutritional status. So what they have to be able to do is heal from surgery.
Right.
And we'll talk about that a little bit more later, but they have to, sometimes people living with mesothelioma, they don't have good appetites, they get full quickly for various reasons. So we want to make sure that nutritionally they're in good shape, because we need them to heal after surgery. So those are the 4 big safety things that we look for. The other 5th safety thing is are they mentally ready for surgery? So it's a big undergoing for people to go through this surgery. At the same time, they've received the diagnosis of mesothelioma. So it sometimes is just too much mentally for someone, to face a big operation after.
Yeah.
So learning to live with the diagnosis of mesothelioma. So I feel like the mental aspect of being ready for surgery is equally as important as all the other safety aspects of it. So once people jump through all those hoops, off all those boxes, at the same time, we're also evaluating, does it make sense from a cancer standpoint? And the criteria that we use, some of it's involved in the staging system for mesothelioma, some of it isn't. So patients will have CAT scan of their chest and abdomen with contrast. That tells us, is the disease limited to one side of the chest? We have had patients present with bilateral mesothelioma. It's rare, but it happens. Some people will present with dual compartment, meaning it's in the chest and it's also in the abdomen. And some patients will, so it's located on one side of the chest. And then as far as the tumor volume and what it is doing in that area, is it something that we can predict that we would be able to safely remove time of operation? So for the most part, that area would be if there's great vessel involvement, if the aorta is involved, or if there's some structures. But given the surgical techniques in 2025 and the backup with cardiac surgery that sometimes we have, it's for the most part rendering a patient without any evidence of disease. We're usually able to move that forward. And then we'll get a PET scan. And does the PET scan show disease anywhere else in the body? And we get brain scans. Mesothelioma rarely spreads to the brain, but have we seen it? Yes. So you want to make sure that the disease is located to one side of the chest cavity. So those are essentially the broad stroke criteria for someone going to the operating room for mesothelioma.
Does the cell type matter?
Yes. So I alluded to the staging system, and that particular prognostic indicator is not part of the staging system, but it is very important for us. So before surgery, most patients will come to us having already had a diagnosis. If they have had a diagnosis, we will send their pathology slides to our pathologist. If the diagnosis is made only on pleural fluid, then that patient will have to have a more substantial tissue biopsy. The reason being is that exact question: what is the subtype of the mesothelioma? Is it epithelioid? Is it sarcomatoid? Or is it somewhere in the middle, what we call biphasic? So patients with purely sarcomatoid mesothelioma generally are not considered surgical candidates, 100% not up front. But we have seen people go to the operating room after a durable response to immunotherapy and chemotherapy. But for the most part, surgery is not the first step for that patient population. Epithelioid, on the other hand, is a more favorable diagnosis. So those patients, we will consider surgery up front. The other prognostic indicator that, again, is not part of the staging system, females for some reason do better than males in general. And whether or not you've had any other procedures in your chest cavity. Some people will have had talc pleurodesis as part of their managing the pleural effusion pre-diagnosis or at the time of diagnosis, and that doesn't preclude someone from having surgery. That's not a exclusion criteria. It makes it a little more exciting for the surgeon at the time of operation, because it's the chest cavity is kind of socked in with the talc, but that's not something that is an exclusion criteria.
Okay.
But patients ask us that a lot.
Okay. Is a patient offered surgery right after they're diagnosed? Is this an early on procedure, or do they have neoadjuvant treatment first? Neoadjuvant, for people who haven't heard this term before, means like chemotherapy before. Yep.
So the short answer is it depends. So again, once our patients have gone through all of the jump through all the hoops that they need to do, whether or not they're having chemotherapy, immunotherapy, surgery, combination. So once we have all that information, we review a patient's case with our team. All aspects of the patient, tumor histology, radiographic workup, safety profile, and as a team, we make a recommendation. If there's a clinical trial that a patient is eligible for, certainly their treatment will be dictated by the clinical trial that they're involved in. But generally it's a multidisciplinary decision what treatment we offer patients. If I would say in general, the epithelioid patients that are fit for surgery, will offer them surgery first, followed by chemotherapy or immunotherapy. People that are diagnosed with biphasic mesothelioma, 100%, we would recommend them to get started with a systemic immunotherapy regimen.
Another question patients ask is, if they were diagnosed and have been on treatment for a while, are they still a candidate? Some people think that window is only at the very beginning when they were diagnosed. Can they have surgery at any time? or is this something that only can happen when they're first diagnosed?
Yeah, no, it does make sense. And yes, they can, starting with immunotherapy or chemotherapy doesn't burn a bridge for surgery. But you kind of have to go through all of the hoops that we talked about earlier, in the cancer standpoint. So no, it doesn't burn a bridge. I would say sometimes with the immunotherapy, patients will have side effects of the immunotherapy that make surgery, a bit of an unsafe endeavor. If they have kidney involvement, or we've had patients that become diabetic on the immunotherapy. So, but I personally haven't seen someone that was treated up front with immunotherapy or chemotherapy that was the reason that they couldn't go to surgery. So, yeah, it's okay.
Yeah. If a patient is found to be a candidate, is there anything they can do to be prepared better for surgery, either mentally, physically?
Yeah, I think preparing for surgery, aside from all the things that we talked about, patients will often ask me, what can I do? What should I be doing? What do I need to change? We can start with nutrition. So this is not the time to, go on a dramatic diet change. It's not, no keto or anything like that. A good balanced diet, that you're not losing weight. If a patient is losing weight, you want to reverse that process. So getting in to see a nutritionist, and getting some recommendations with respect to that. So paying close attention to not losing weight. We don't want you to gain weight either, unless you need to. But for the most part, maintain your weight, maintain a good balanced diet. For people that have early satiety, because they may have a pleural effusion on the left side that is pushing down on their stomach. It's good to do small frequent meals, snacking. If you have to go to the doctor's office for something, make sure you always have a snack in your bag, an Ensure or some type of dietary drink. So nutrition is important, exercise is important. So again, not the time to start powerlifting or anything like that, but good cardiopulmonary, walking. People do yoga, if people do Pilates, or kind of good conditioning exercises. No matter what your treatment is, nutrition's important, exercise is important. Exercise will help with the mental aspects of it, and making sure that you are supported mentally, that you have someone to talk to, that you are getting answers to your questions, that you understand what the plan is. I think that's where nurses play an incredibly critical role in the care of mesothelioma patients, is making sure that they do feel supported and they understand. They can ask questions, and they can ask the same questions over and over until it's straight in their head, because it's for many people, especially at the beginning, it's like an outer body experience. So I think nutrition, exercise, and mental health is important. Be around people that make you happy. Don't listen to other people's cancer stories. Focus on your story. And all of these things are easier said than done. So the other part of it is have your cancer care team, your spouse, your children, your best friend. Surround yourself with people that lift you up. And I saw somebody yesterday, and she told me, I'm just trying to keep everything as normal as possible. I know things are going to change, but I'm trying to keep things as normal as possible. And I thought that was really good. Like, really kind of focus on, you still have to take the garbage out. You still have to make sure your bathrooms are clean. Keep engaged in your life, because our goal is we're going to put you back there. We're going to get through all these treatments, and we're going to put you back there in your life. So keep it together. So you have that to come home to.
Can you sort of walk us through the steps of the lung sparing surgery and how long it takes, and like the sort of, I mean, there's risks to everything, but just sort of the main risks that
Sure.
someone would expect.
Sure. So the surgery is done. It's a procedure that takes all day. Patients come in the morning, go through the normal prep, and then go off into the operating room. The procedure is done under general anesthesia, so you're completely asleep. And the incision is called the thoracotomy incision. And what that means is it's an incision on your side, starts up around your scapula and comes around and ends up kind of not under your armpit, but on your side. So it's
like the C incision, right?
Yeah.
Yep.
So it's and you know, the reason for that, there are some centers that I've read about that do minimally invasive or robotic, but given the job that needs to be done at the time of operation, it's for the most part an open procedure, as we call it. Once the surgeon is able to get into the chest cavity where they need to be, sort of inspect, kind of get the lay of the land, look up at the top of the lung, look down at the diaphragm, just kind of assess the situation, and then begin to take the pleura off of the chest wall, off of the lung. Taking it off of the lung is a very gentle, tedious procedure, and if you want to visualize it, it's almost like the lung is encased in an orange peel. So what the surgeon will do is make a slice in the orange peel and just push away the lung and just peel the mesothelioma off the lung. If it's involved with the diaphragm is then, whatever has to happen with the diaphragm. If it's involved with the pericardium, the lining of the heart, whatever has to happen based on an individual's extent of disease. So all those structures are assessed, and the mesothelioma is removed from all of those areas. Specimen is taken out en bloc, which means all at one time, and any structures that need repair are then repaired, and then what we do is we do an intraoperative adjuvant treatment, meaning at the time of operation, we talked earlier about the microscopic disease that's left behind. This is a golden opportunity to do something about that, those cancer cells that we know are there. So we do what is called heated intraoperative povidone iodine lavage. And what that is essentially betadine. We heat to negative 40 degrees Celsius. I might have that temperature wrong, but we heat it up. And we lavage it into the chest cavity, let it dwell, suction it back out, do it again. So we do that 3 times. And that's actually a technique that started in the UK that we've adopted here and that we've been using for many, many years. And I think that the toxicities or side effects after surgery, it really doesn't add anything to it, but it really does help control that microscopic disease. There are other intraoperative adjuvants that are used throughout the United States and the world. Some people do intraoperative photodynamic therapy, which is a light-based cancer treatment. We were involved in a clinical trial for that. Some people do heated chemotherapy, which you've heard of HIPEC, which is done in the abdomen. Well, this is done in the chest. Some people use fibrinogen with chemotherapy. So there's a lot of different variations, but I think it's important to ask that question if you're talking about surgery, is what do you do at the time of operation to address microscopic disease? So once all that's said and done, that takes anywhere from 6 to 14 hours, depending on the extent of disease.
Yes.
Patients are, before we close the chest, we put chest tubes in. Those are surgical drains that help us to keep the lung expanded after surgery, and also monitor for any bleeding after surgery. And also we monitor air leaks. So that's one of the probably the biggest, I don't want to necessarily call it a complication, but it's one of the outcomes that we see immediately after surgery, because we've taken the tumor off of the lung itself. It will have little tiny air leaks, which all need to heal. And we talked about nutrition and why nutrition is important. This is one of the reasons, is we need those tiny air leaks to heal. So we put the chest tubes in. Patients will have IV monitoring. We monitor their blood pressure, their blood gases. So our patients go right to the intensive care unit. We take the breathing tube out at the time, in the operating room. I don't know what the percentage is. I'll just say 50% of the time. That's not exact, but most of the time we will leave a patient asleep overnight, or with a plan to take the breathing tube out in the morning. And honestly, that kind of depends on the length of the procedure and the length of general anesthesia.
Okay. So in terms of when I said the main risks, or not risks, complications, you said were basically the bleeding and the air leaks are the main
so we're looking, we're monitoring for bleeding, and usually that once we roll out of the operating room, bleeding is generally not something we're worried about anymore, but we certainly monitor for it. We monitor the air leaks that they're sealing. We look for, patients need to have a nice strong heart, because sometimes they'll develop arrhythmias, heart arrhythmias. Atrial fibrillation is the one arrhythmia that we most commonly see. And then the rest of the care is really kind of combating other surgical risks. So we get people up out of bed, walking.
Yes.
We do a lot of what we call chest physiotherapy. So a lot of spirometer. Patients have pneumatic compressions, boots. They get subcutaneous heparin to make sure they don't develop clots after surgery. They're up and moving so they don't develop, slow intestines. So we can get them to start eating again, getting them to move their bowels. The pain medicine that we give to patients can be very constipating, but is very effective in getting people up and moving and coughing, which is a critical aspect of recovering from this surgery. Nutrition wise, at our center, we put people on parenteral nutrition immediately afterwards. So they're right out of the gate getting nutrition until we're able to start, a regular diet, because nutrition and healing is so important.
So for people who don't know, sorry to interrupt, that would be the nutrition that goes through the IV.
Into the veins, yep.
Right.
Yeah.
So they would be getting fed through the IV.
Yeah.
This sort of, what you're explaining leads me to my question is, what would they be prepared for right after surgery? So when a patient wakes up, they would find themselves in the ICU. And they would have the chest tubes in, they would be getting fed the parental nutrition, which is through the IV, and they would not be eating, correct?
Right. We don't feed people right away because, and they'll often have a tube in their nose draining the contents of the stomach, because general anesthesia slows everything down, including your intestines. And what we don't want, especially for people that have had any type of work on their diaphragm, is we don't want those patients vomiting. So we keep their stomach empty until it wakes up, and then we can take the tube out. And generally that's about 24 hours that the anesthesia gets out of the system, and we can take the tube out of their nose, and they can start having ice chips and dial up as they tolerate.
Some patients are concerned, the biggest concern I hear is they're worried about their pain being managed. So how is
that-
that handled right away?
That is an absolute concern of everyone, and it's top priority for us. I would say, having been a thoracic surgery nurse for a long time, we have come light years in managing pain after surgery, after thoracic surgery in particular. And I think that staying ahead of the pain from the get-go is very important. And our goal is for you to leave the hospital and say, oh, that wasn't so bad. You know, my pain, you're not going to have no pain. That's unrealistic, but you should have a very low amount of pain, which allows you to cough, deep breathe, walk. So we use thoracic epidurals, which are, you know, tiny catheters in the spine itself. Most people are familiar with them with child birth, but this is it within the thoracic spine. So patients are able to walk, they feel their legs. You know, there really aren't any ill effects of the thoracic epidural. So that once we
Very effective.
It's revolutionize what we can do in the chest for sure.
Good. What are some of the common challenges after discharge in the first few weeks that a patient could expect?
Yep. So once we're ready to send someone home, we've seen them kind of essentially do everything we want them to do at home. So we've walked them up and down the stairs. They can go into the bathroom. We know that they have good activity tolerance. They can walk around the unit multiple times throughout the day. They're eating, moving their bowels okay. Pain is well controlled. All their tubes are out. Once patients go home, I think the first couple of days are kind of, I don't want to say scary, but unsettling in that now you're home alone, you know, without all this medical attention that you're getting. So I think transitioning into home, making sure people understand we're not sending you home until we know you're going to be okay, and preparing people for that. So, you know they have to have a walking regimen. They need to have a good diet. They have to stay ahead of their pain medicine. So a lot of good preparatory education before we launch them home. And then focusing on, so the recovery from the surgery isn't anything fancy. It's the basics: moving your bowels, moving your body, good nutrition, staying ahead of your pain, getting sleep. People are so happy to be back in their beds, but understanding it's going to take a while to get your sleep pattern back to normal. We've completely disrupted that at home, in the hospital. So just sort of being kind to yourself, but keeping all the same principles that you've, for the past couple of weeks have done in the hospital.
Yeah. I've heard a few patients say that they didn't realize when they got home that they had trouble sleeping in a lying flat position, and they ordered like a square pillow for at home, a wedge, or they had a recliner, or do people find that helpful?
Yeah, I think that's I've heard that not only with this particular surgery, but at, our lung cancer surgery patients. Some people are just more comfortable. Although they're safe to lay flat, they don't drop their oxygen saturations, their blood pressure is fine. Some people just don't feel comfortable laying flat right away. So a recliner, they can get those wedgies. I discourage people from ordering a hospital bed, because I just feel like I want you to mentally feel like you've made some good progress. Right. So getting
back to life. It's hard to get back to life when you're in a hospital bed.
Yeah. But up and down the stairs, up out of bed, get dressed. You can take a nap, but you're not in bed all day.
Right.
You can dry the dishes, you can make yourself an egg sandwich. So just kind of doing all the, certainly I'm not going to ask you to, bring the laundry down in the basement and carry it back upstairs, but you can fold the laundry. So kind of getting back into your activities of daily living. I do tell people to make sure that anybody that comes to visit them that they're not sick. So, and just because the last thing people need when they're recovering from chest surgery in particular is to develop any type of flu or upper respiratory tract infection. And you are, you're vulnerable just because you've just been through a big surgery. So, people mean well, but when the grandchildren come over, make sure that they don't have the sniffles.
Right. How closely are they followed with the schedule of follow-up appointments? And how long does it take for a patient to feel back to, quote, normal or pre-surgical?
So we see people 2 weeks after surgery in the office with a chest x-ray. And at that point, people feel like they still feel a little banged up, but are starting to have more good days than bad days. And what was your second question?
I'm sorry. I said how long before they start to feel normal again? Yeah.
So the answer to that is the better shape you're in, this better shape you'll be in. So this is where being, fit for surgery is very important. So if you go into this operation in your best possible condition, which is sometimes difficult with the effects of mesothelioma, the better shape you'll be in. Also, the more you put into your recovery, the more, I tell people walk a little bit more each day. If you follow that, rule of thumb, you're gonna speed along your recovery. If you're sitting in a chair every day or going back to bed, your recovery is going to be longer. So if I think what you put into your recovery will dictate in many respects the length of time it takes for you to feel back to normal. But
so it's different. Huh?
Yeah, it's different for everyone. But I think most people at the 3-month mark feel like they're back to normal. Okay. But then again, those patients are also looking at starting chemotherapy potentially or immunotherapy. So the recovery period is really important that you focus on getting your strength and stamina back.
And that was another question that I get often is, after surgery, do you need to have a treatment? Are you following up with a treatment?
Yeah, I would say the majority of people are. Okay. So that we say we should get you back to treatment. Everybody's different again, but like within the 6 weeks after, you should be ready to get started.
Okay. I think last question, I've taken a lot of your time. What advice would you have for patients to cope with this big surgery, with the emotional challenges of this surgery and the recovery?
I think that having a good support network is important. I think talking about what you're thinking is important. People will, if you're a stoic person, not used to sharing your feelings, I think, men in particular, not to be sexist, but, most older men don't want to talk about their feelings. They're handling life, and they're, everybody's depending on them. So when the tables turn, I think it's important to accept the love and support your family's giving you, and allow that, because you need that attention, and so don't deny your feelings. Talk to them, get help, talk to your primary care doctor. Yes. In cancer centers, there are psycho-oncology specialists that we refer to a lot, because we as nurses can help just so far. We know that a person needs some extra help, or whatever. So talk to the nurses that are caring for you at your cancer center, and then just keep yourself in the best possible shape. Ask questions. Ask questions. Make sure you're comfortable with whatever the plan is, that you understand the plan, and write your questions down. And so when you get to the doctor's office, or somebody calls you, you don't forget.
Yeah.
I went to the doctor last week, and I had one big question that I forgot to ask. I had to go on
Yes.
my portal and ask the question. And, so just bring your notebook and
Yeah.
make sure that you're comfortable. That's what we're here for. If
Yeah.
anybody rushes you through your list of questions, then, then move on. Because
Right.
with mesothelioma, more than any other problem I've cared for as a nurse, I think this is a tough one to totally understand the plan and whatnot. So get your questions answered.
Well, thank you, Melissa. You have been invaluable, and I think this is going to help a lot of people. So
I hope so.
Thank you so much for being here today. Thank you.
My honor. Thank you very much.
Thank you.